First of all, I would like to thank the Committee of Organization and Professor El Ghazli, Professor Mostafa, and Professor Refki for their very kind invitation to speak in your Congress. It's a great pleasure for me to be there and to represent the ESGO colleagues who are discussing with you. And it's a great pleasure for me also to mention the very strong connection that we have with colleagues from Egypt and surrounding countries in terms of collaboration, in terms of future collaboration between your societies and the ESGO. Thank you very much for your invitation, and I'm very pleased to discuss with you the interest and the modalities of surgical staging surgery in patients with locally advanced cervical cancer. As you know, the presence of paralytic nodal spread is the strongest prognostic factors in cervical cancer. So, the impact of paralytic spread is strategically a key issue to determine the therapeutic management of patients. When patients have isolated positive pelvic nodes without paralytic spread, the conventional treatment is based on chemoradiation therapy. When patients had a nodal spread above this level, the key issue is whether to extend the field of chemoradiation therapy up to the level of the renal vessels, or to give adjuvant chemotherapy if the disease is outside from the field of the paralytic area. The prognostic impact of paralytic nodal spread is related to the size of the nodal metastasis. And we know, in example, in this retrospective study of Eric Leblanc in Lille, that the survival of patients with nodal spread below that 5 millimeters is very close to the patient without any nodal involvement. More recently, we published data of 3 centers, Lille, Gustave Roussy in my centers, and Toulouse in the center of Denis Kerleux, a prospective analysis showing that the survival of patients with a very small nodal spread in paralytic area is the same that patient without nodal metastasis. This means that if a paralytic staging surgery is required, is to try to screen these patients with a very small size nodal metastasis to try to give them the same chance to be cured than the patient without any nodal spread in this area. You can see here the survival curves of patients without nodal metastasis and patients with a small size nodal metastasis. So in terms of overall survival, we have a very similar curves in these two groups of patients compared to the very poor prognosis of patients with bulkier nodal spread. This means that even if the surgery can screen patients with a very small size nodal metastasis in paralytic nodes, we have not yet currently the good way to treat patients with a bulkier nodes in terms of attempt to cure them. In the recommendations from the ESTRO, ESGO, and ESP, paralytic lymph node stagings appear as an option to screen patients for paralytic nodal spread. And if so, the question is the level of the dissection. Some of the authors are recommending to do this dissection up to the level of the inferior mesenteric artery that appears as being sufficient in terms of screening patients with nodal spread. But this is currently remaining hot questions up to date. You had 4 different trials testing the impact on survival of the staging surgery, comparing surgical staging and radiological staging procedures. The oldest trial was the trial from Lai, comparing surgical staging by extraperitoneal or transperitoneal approach and radiological staging. And this trial had been closed prematurely due to the fact that the overall survival of patient was poorest in patient surgically staged compared to the patients staged on the basis of imaging alone. You can see here the curves of patients treated surgically with the PFS and overall survival curves, and their surgical staging in this trial was deleterious in terms of impact on the overall survival. This explains the closure of this trial prematurely. But in this randomized trial, we have a low number of patients with 32 patients with an high morbidity of the surgical staging. And as I told you, this trial has been closed prematurely due to the difference in terms of survival in the arm of patients surgically treated. The surgical staging remained the standard of care in my center in patients without uptake in paralytic area during initial PET-CT imaging. But in few cases, we have some patients that have not underwent this surgery for different reasons, the age, the morbidities, etc., etc. And Cyrus Chargari, the chief of radiation oncologist and brachytherapist in my centers, have published recently the survival and the outcomes of patients according to the status of this management. And you can see that the curves and the survival of the patient is better in patient undergoing a surgical staging compared to patient without any staging or patients with paralytic lymph node metastasis on the basis of PET-CT imaging or results of surgical staging. This means that in this retrospective analysis, this staging could have a benefit in terms of impact on the survival of patients, but that is the result of retrospective analysis. With a similar methodology, Christophe Pommel demonstrates exactly the different results with the absence of impact on the survival of this surgical staging compared to what is observed in patient in terms of survival in patient treated with on the basis of imaging alone. Here are the curves of patients undergoing a paralytic node staging in cohort 2 or patients treated on the basis of radiological staging in cohort 1, and you can see the advantage on the survival of the treatment decide on the radiological staging alone. More recently, in a large cohort of patients, DABI demonstrate that the surgical staging impact positively the survival of patients on comparing more than 600 cases of patients with or without surgical staging. Here are the curves of these groups of patients. In red, that is the case of patient with surgical staging, and in black, is the curves of the patients without surgical staging, showing the impact on the PFS of the surgical staging, but also the impact on the overall survival itself, meaning that in this study, the surgical staging impacts positively the survival of the patient. In the multivariate analysis of factors influencing TFS or OS in this study, the use of surgical stagings is one of the two factors that have been demonstrating as impacting the overall survival of the patients. So, how can we go ahead with these different results? First of all, the accuracy of CT scan alone or MRI is not so good, and we are missing probably 20 to 25% of patients with nodal metastasis when we use this imaging alone. When you look at the morbidity of the surgical staging, the morbidity is low if this staging surgery is done by laparoscopic approach, but it is low in a group of patients and in a group of teens who are really skilled for the surgery and in the group of patients who are selected for the surgery. This means that you should have expert centers if you use a staging surgery to decrease at the minimal level the postoperative morbidity, because if you have a major postoperative morbidities after a staging surgery, you will then impact after the outcomes of the patients, extending the delay before to begin the chemoradiation therapy. That is not an acceptable risk to extend this delay. We have published recently in Lancet Oncology with Sébastien Gouy and different colleagues with Eric Leblanc and Denis Kerleux, the current results of the different series about correlation with PET-CT imaging and surgery in locally advanced cervical cancer. And we know that the false negative rate of paralytic imaging during PET-CT is of 12%. When you have a patient without positive uptakes in pelvic area, this rate is close to 6 to 9%. But when you have a positive uptakes in pelvic area without uptake in paralytic area, nearly 1/4 of patients will have an microscopic nodal involvement screen during the paralytic staging surgery. This means that if you will not go to a staging surgery with laparoscopic approach in patients with positive pelvic uptake on PET-CT imaging, you will miss 1/4 of patients with positive nodal spread of a small size. And this is also this patient with a small size paralytic spread that could be cured when you extend the field of chemoradiation therapy, as I show you previously in the previous slides. So, when you balance all this information, you can see on the left side that the accuracy of the PET-CT imaging is better that you observe with pure CT or MRI, but you have 12% of false negative rate, up to 22% if patients have positive pelvic uptakes. On the right side, you have the rate of morbidity of the laparoscopic approach that remain very low in the hands of trained surgeons to do this kind of surgery. The other important information that we get from the paper that we published in GCO 7 years ago with Sébastien Gouet is that if you incorporate the PET-CT imaging in the screening of the patients, in the screen of the metastasis of the patient with locally advanced cervical cancer, and if you use a paralytic nodal surgery, you cannot extend the delay outside from the acceptable delay of 45 days. If you exceed 45 days between the PET-CT and the beginning of chemoradiation therapy, you will have a deleterious impact on the survival of the patient. So this means that if you use a PET-CT imaging and a staging surgery, you should do it by laparoscopic approach to decrease the morbidity at the minimal level, but you should proceed to the scheduling of the chemoradiation therapy during the 2 weeks after the laparoscopic approach to avoid an extending the delay between the PET-CT imaging and the beginning of the treatment after 6 weeks after the imaging. Recently, Simone Marnix presented the last year the very important results for the Uterus 11 trial that show us that we have no difference in terms of morbidities between two groups of patients, surgical or radiological, but on the other hand, you have no any impact on the survival of the use of a surgical staging compared to patients treated on the basis of radiological staging alone. This means that this trial failed to demonstrate an impact on the survival of the use of the staging surgery, even in the hands of surgeons trained to do this surgery or teams used to integrate the staging surgery in the management of patients. The two other trials, Lilac trials from Michael Fromovitz, have been prematurely closed due to the insufficient inclusion of patients in this very important trial. And similarly, the Pole Disc trials, testing also the impact on the survival of the staging surgery, had been also closed due to the lack of inclusions. This means that we will never get the final response of the impact of the survival of the use of this staging surgery or the absence of impact on the survival of this surgical staging surgery. Can we expect from now an improvement of the screening with a new generation of the PET-CT device? We tested recently in a paper that will be published very soon, comparing the accuracy of the PET-CT imaging in the previous generation of the machine compared to the new one. And you can see here that we have no difference in terms of false negative rate with the previous generation of the imaging and the new one. This means that until now, it is not the type of machine used for the PET-CT imaging that can decrease significantly the number of false negative rate and then could raise the question of avoiding the surgery due to the fact that the PET-CT imaging alone can screen the higher rate of patients with positive paralytic nodes. So, how can we combine all these parameters to know if these surgical stagings change the survival of the patients? This depends on the PET-CT imaging results. If you have no any extracervical uptake, due to the fact that the false negative rate is close to 5 to 7%, we decide in mind centers since 3 years to do not continue to use a paralytic staging surgery in these cases. If the PET-CT imaging show on the right that you have paralytic uptake on the PET-CT imaging, you have no indication of the use of staging surgery because you have the information that you are expecting, meaning the spread up to the level at least of the paralytic nodes. But we continue to use this paralytic staging surgery in patients with positive pelvic uptakes because we know that in this subgroup of patients, 1/4 of these patients will have a microscopic nodal involvement in paralytic nodes. So in this case, you have two options, whether to use a staging surgery by laparoscopic approach in the end of trained surgeons to decrease the morbidities, whether to extend the field of chemoradiation up to the level of left or right renal vessels in patients with positive pelvic uptakes, but you will then expose 3/4 of the patients for the useless morbidities with the extension of the field of radiation therapy up to this level. This is why the option that we choose in this case is to continue to use a staging surgery by laparoscopic approach in the subgroup of patients with positive pelvic uptake. To conclude, the impact on the survival of staging surgery remain until now unproved. So it is a question of balance between morbidity, false negative rates, but also experience of the teams and the surgeons. The rationale to continue paralytic lymph node stagings remain in the group of patients with uptake of PET-CT imaging, but there is no rationale to continue this staging surgery in patients without any pelvic uptakes. Thank you for your attention and good meeting. See you soon in the next event from the ESGO. Take care of you and your family. Bye.